I'm Dr. Andrew Siegel. It's now late July 2012, and we are long overdue for a Horse's Ass Award. This time, the Horse's Ass Award goes to the USPSTF. That is the United States Public Services Task Force, who recently recommended against PSA testing, prostate specific antigen testing in healthy men, stating that the benefit does not outweigh the potential side effects. Those in the know have grave concerns about this recommendation, and I use the word grave very specifically and chose that word very carefully, since this is a tremendous disservice to those who may benefit from early prostate cancer detection and treatment. Essentially, their recommendation sabotages the art of well-informed and nuanced medicine, replacing nuanced medicine with this shotgun, one-size-fits-all approach. Mark my words, if this recommendation is adhered to, men will die unnecessarily. I repeat, men will needlessly die. So what are my qualifications to be able to render an opinion to you? I am a urologist, one who specializes in diseases of the urinary tract, and prostate cancer is a large part of our practice. I have had 25 years in the trenches, so to speak, at the front line in the fight against prostate cancer. Additionally, I'm very interested in public health. I will likely choose public health as the third chapter of my career. And this is clearly a public health issue of grave importance. And finally, I'm the son of a prostate cancer survivor who will soon be 81 years old and is live and well and thriving and enjoying his later years due to early prostate cancer detection. His disease, of course, puts me at higher risk for prostate cancer as well. It is an absolute indisputable fact that prostate cancer is the most common non-skin cancer in men. 1 out of 6 men in their lifetime will ultimately come down with prostate cancer, accounting for about near 250,000 new cases per year. It is the second most common cause of cancer death in men, accounting for roughly 33,000 deaths per year. And therefore, it is a significant public health problem. It is also an indisputable fact that prostate cancer death rates have dropped dramatically since the PSA era, which was 1992. Approximately 4% decrease per year since 1992, and an examination of Medicare database reveals that there has been a 75% decrease in advanced disease at diagnosis during the PSA era, and a 40% decrease in the death rate. Now that is significant. And I don't need to look at database numbers to appreciate this. I've been around long enough that I see it in my practice. Now, that stated, I do agree with the USPSTF that there has been too much aggressive treatment of prostate cancer meted out and not enough conservative management, active surveillance when it's relevant. But this is clearly a separate issue from PSA. And the PSA should not be thrown out because of the potential for overtreatment. So what is the PSA test, prostate specific antigen? It's a simple, inexpensive blood test that can help identify men who merit a prostate biopsy. Now, before deciding on a biopsy, the PSA is put in the context of the patient's personal PSA history from year to year and integrated with other factors and information such as the digital rectal exam, family history, general health, and other risk factors for prostate cancer so that an informed and nuanced decision can be made. Now, I have a bunch of problems with the USPSTF. If you go on their website, you can get a list of their membership. And if you scrutinize their membership, you will find that their chairwoman is a pediatrician. Pediatricians do not treat prostate cancer. There is not a urologist, a radiation oncologist, or a medical oncologist in the group. Only internists, pediatricians, family physicians, nurses, and gynecologists. Hello? The USPSTF has put out lots of literature for patients and physicians. This is guidelines for physicians. And I want to take some of their conclusions and argue them for you. One conclusion. In most cases, prostate cancer does not grow or cause symptoms. Well, I beg to differ with that. Prostate cancer starts out as a mutation, like all cancers. It begins as a small focus that is not detectable on rectal exam and is only capable of being diagnosed with a PSA test. It will then slowly and gradually progress to the point that it can be felt on rectal exam. If left untreated, it will then advance locally. Ultimately, it has the potential to spread to peripheral organs, most commonly the bony skeleton. There is little debate that successful prostate cancer outcomes depend on early detection, and studies have clearly demonstrated that screening can effectively detect the disease. Their next conclusion. If it does grow, it usually grows so slowly that it is not likely to cause health problems in a man's lifetime. Well, that's not the case. Prostate cancer truly is often a slowly growing process and can take many years before progression and spread, sometimes 15 years, sometimes 20 years. And for this very reason, 10-year survival data is not sufficient to properly gauge the effectiveness of screening and treatment. And many of the conclusions of the USPSTF were based on 10-year data and studies. Their next conclusion. Currently, it is not possible to reliably distinguish indolent from aggressive cancers. That is sometimes the case. It can be challenging, but when you look at all the factors, including the absolute level of PSA, the change in PSA over time, the Gleason score, which is a grading for prostate cancer, the number of biopsies showing cancer. Typically, we do a dozen biopsies. It's very different if you get one biopsy showing cancer from 12 biopsies. The percentage of each core that shows cancer, very different if it's 5% versus 100%. The findings on digital rectal examination. Generally, if you can feel it, the prognosis is worse. All these factors integrated together can give you a pretty good idea as to what is indolent and what is aggressive. So the PSA test is simply a means of helping identify men who merit a biopsy. And a biopsy that reveals cancer should then lead to an intelligent discussion between urologist and patient regarding management options, including observation, which is active surveillance, as some men will never require treatment. Some of these men who are on active surveillance who are followed will then ultimately need treatment if the disease progresses to a certain extent. A biopsy done as a result of PSA screening can help discern men who require immediate aggressive treatment as a life-saving measure. If the PSA is abandoned, these men will miss their chance for cure and may become one of the more than 30,000 American men who die annually from prostate cancer, once again, the second leading cause of death for men. Prostate cancer death generally is not a pleasant form of death. It often causes painful, bony metastases, pathological fractures, spinal compression, and often upper and lower urinary tract obstruction. The task force completely neglected to focus on this aspect of prostate cancer. So PSA screening, performed in an intelligent and nuanced fashion, will provide valuable information that is capable of saving lives. There are essentially no risks to screening or side effects to screening. And to deny patients this test because of concerns regarding the potential side effects of treatment that they might never need is ridiculous and is clearly not good medicine. I would like to show you a few biopsy results of the range or gamut of biopsies that we see in clinical practice. This is a diagram of the prostate. It is divided into a dozen zones because generally 12 biopsies are obtained. This was a 62-year-old man who came in with a PSA of 8.6. All the circles represent benign biopsies, 11 out of 12. One biopsy had this tiny little focus of prostate cancer, approximately 5%, reasonable grade. He was diagnosed a few years ago. I have been following him with observation, active surveillance, watchful waiting, and he's doing absolutely fine. This is the other side of the spectrum. This is a gentleman who came in with a markedly elevated PSA that 2 years before was normal. He's 77 years old. Every single one of the biopsies was positive, involving a large segment of each core. This was very high Gleason score, 9 out of 10. This is a man who demands immediate, aggressive treatment. And granted, treatment might not be sufficient to save his life. But by recognizing and diagnosing this early, he can get a number of good years of quality of life, with good quality of life. And this is a more typical intermediate biopsy. This is a 52-year-old man, healthy man, peak of life, PSA 8.9. PSAs have gradually risen over the course of the last several years. I just saw him recently for the first time, sent in with a PSA of 8.8. I repeated 8.9, biopsied him. He has 2 biopsies that show premalignant areas, 3 biopsies that clearly show cancer in a good amount of each core, and he is an ideal candidate for treatment. He's 52 years old now. If he is not treated, ultimately this prostate cancer will spread locally, advance to his bones, and he will die of prostate cancer. And it might not be for 10, 15, or 20 years, but he's 52 years old. If this man was denied PSA screening, he would essentially be doomed to death. So the USPSTF recommendation represents a step backwards. Come on now. We're in the 3rd millennium. Let's not get back to the 2nd millennium. It will not benefit public health. I ardently oppose the recommendation. There are some additional concerns as well. Additional concerns are the medical legal implications of foregoing a non-invasive blood test that can screen for the most common male cancer. Years down the road, when patients come in with advanced metastatic prostate cancer and they were unscreened, who will ultimately be responsible for the failure to diagnose on a timely and treatable basis? I personally strongly believe in proactive, preemptive, preventative measures to maintain our health. That means healthy eating, maintaining a healthy weight, exercising, staying active, and participating in screening for diseases that can be picked up in their early and treatable phases. This week I went to my dentist and my eye doctor for those reasons. I see my internist annually for preventative maintenance and screening for occult illness. That is, illness which causes no symptoms, such as high blood pressure prostate cancer, glaucoma, etc. The PSA test is a vital part of this screening. Perhaps most telling is the fact that 95%, that is 19 out of 20 urologists, those at the forefront of evaluating and managing prostate cancer, are themselves tested on an annual basis. And I certainly will not forego testing on myself. I have a 1 in 6 lifetime chance, which is probably up to 1 in 3 because of my family history. And I want to know if I develop this disease early so that I can get it treated in an expedient manner. In my humble opinion, information is good. And PSA is exactly that, information. It has and will save lives. For more information, including a PDF copy of my booklet, Prostate Cancer Second Opinion, this is free, go to our website, www.bergenurological.com, bergenurological.com. It's a comprehensive website. There are links to lots of educational materials, including videos, written information, my books, as well as my weekly blog. Thank you very much for your attention.